Good afternoon and welcome to the Alliance for Home Health Quality and Innovations webinar on leveraging home health and mobile technology to reduce readmissions. My name is Teresa Lee and I'm the Executive Director of the Alliance. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire U.S. healthcare system. The webinar today will focus on reducing avoidable readmissions from home health by leveraging paraprofessionals and mobile technology applications. We're so fortunate today to have as our guest speaker Dr. Andrey Ostrovsky, CEO and co-founder of Care at Hand. Andrey is a practicing physician and social entrepreneur who leads Care at Hand's executive management and strategic vision. He has contributed to informing legislation at the city and national level to advance care delivery for vulnerable populations. He's a published researcher in public health informatics, rapid cycle improvement, healthcare innovation, and care coordination. He's currently completing his pediatrics residency program at Boston Combined Residency Program at Boston Medical Center and Boston Children's Hospitals, and is a clinical instructor at Harvard Medical School. Just a few housekeeping notes before we get started. First, Dr. Ostrovsky will speak for approximately 40 minutes and will leave about the last 15 minutes to answer questions. Please note that this is a webinar and we will be controlling the slides on our end, so please don't be surprised if you cannot flip ahead. Your lines will be on mute, but you can submit questions to be answered during the Q&A period through the Fuse webinar software on your computers or other devices. And you can send a question to the speaker to be answered in the Q&A period by sending a question to me, Teresa Lee. Finally, we will be posting the slides on the Alliance's website after this webinar, and we're also recording the webinar and we'll post the playback on the Alliance's website. And with that, I'd like to turn it over to Andrey.
Thank you so much. Thank you, Teresa, and thanks for everyone for having me here. Teresa, are you okay if you run the slides and I'll just say next slide?
Yes.
Awesome. Great. Thank you so much. Great. Well, I will jump right in. Very briefly, the goal of this conversation, and I welcome any questions, or we could save them to the end. The goal really is to highlight not so much of my technology. I think we're one of many different types of technologies out there. I think rather the goal is to highlight a process, and that process is quality improvement. And the importance of the process of quality improvement is that it has large implications for how the home care industry and other post-acute care providers can more quickly and more efficiently navigate the pretty quickly evolving reimbursement landscape for healthcare. And so that's the goal of this conversation. I'll sprinkle in a little bit of topics around interoperability, but the primary focus will be around quality improvement and sustainability and how digital health can play a role. So next slide, please. The vision here is really important. I am a pediatrician, as Teresa pointed out, but my bigger picture ambitions and career goals and life goals really are it's not just about kids or elderly or adults. It's about populations who have some kind of functional compromise that should not predispose them to worse health outcomes. And my goal is to empower those populations. And so technology is just one avenue of doing that. Our advocacy and research work is also aligned with how we try to achieve this vision. Next slide, please. So I want to frame the problem. I think the folks on this call are likely familiar with some of these statistics, but I think it's always important to ground us in the hard numbers. This is from 2011 data that quantified or estimated the wasteful healthcare spending in the U.S., and these are numbers with a B billion behind them. And I highlighted this red box to emphasize failures of care coordination, and in particular, if we look at the costs to Medicare and Medicaid, the midpoint is about $30 billion in wasteful spending. due to failures of care coordination. Whether it's 30 billion or 35 billion, it's B. There are a lot of zeros after that number, and what's more important is that it's not just about the dollars, it's about the morbidity and the mortality and the human costs associated with this. Next slide. And a symptom of poor care coordination is readmissions. We are familiar with these numbers, which are now becoming a little outdated. 1 in 5 Medicare patients bounce back every month. 1 in 4 duals. These numbers are improving. Affordable Care Act seems to have made a dent, but the numbers are still not acceptable. Next slide. And a component of readmissions being a symptom of poor care coordination, is poor communication. And this is just a quick reference so folks can always refer back to it. I cited down below the original literature that poor communication breakdowns are a major source of poor care coordination. So if we can get communication nailed, then we can help to address care coordination and improve it, and then ultimately we can prevent readmissions, and then bigger picture, we can streamline how effectively care is delivered and drive down the cost of care. Some of the examples here, 80% of serious medical errors have been implicated in this communication journey handoff process. Joint Commission, they did a review of a decade of data citing the leading root cause of sentinel events being communication breakdown. In Australia, there's data showing about 1 in 10 of 30,000 preventable adverse events led to permanent disability. And then what the optimistic thing here is not all doom and gloom. There is ample literature to show that care transition programs can effectively improve communication. They can effectively reduce avoidable admissions. Next slide. So what is the context we're all working here? I think it'd be great to do a show of hands, but I won't ask if we're doing this virtually, but I imagine that the folks on the call and the previous participants in these types of events are subject to some of the provisions of the Affordable Care Act, whether from a penalty perspective and whether from a penalty now or in 2017, 2018, when potential readmission penalties for skilled nursing facilities or Medicare-funded home care providers will go into effect. Regardless of what element of the Affordable Care Act may impact you directly or indirectly, there are a lot of incentives and disincentives all aligning around shifting where care is delivered. Here I highlight just a handful of those provisions: the readmission reduction program, value-based purchasing, Medicare shared savings, that one being for ACOs, and then bundled payments. Bundled payments I'll dig into a little bit during our conversation here. Next slide. And also that this is just showing the positive incentives. So duals demonstration projects, DCTP, the community-based care transition program, there are other incentives. So it's not all just penalties. Next slide. The key here is this, is that with the care continuum that I'm highlighting in the figure up above is showing that when people get sick, when they are decompensating, the incentives before were more throughput and now continue to still be more throughput and fee-for-service. But increasingly, there is an incentive to push care out to the community and less so provide the care in the acute care setting. And on the right here, I list a more exhaustive list of some of the Affordable Care Act provisions that have that are supporting this transition from acute care out to community-based care. Next slide. And this is just an example that is grounded in actual experience. We work a lot with community-based organizations, and increasingly we're working with Bundle 3 participants, so skilled home care companies. And regardless of what vertical we're operating in, readmission penalties tend to be an area of conversation that gets brought up. And I wanted to frame the current standards of care transitions and how much they cost relative to what a hospital CFO may be considering when they're deciding, do we buy, do we build a care transition program, do we even care about care transitions? And not to be callous or insensitive, but I'm going to put this purely in dollars and cents. If we were to amortize the 30-day readmission penalties that hospitals are seeing now, and if we were to average out what a typical penalty a hospital would experience, the rough cost of a 30-day readmission penalty is about $200 to $250 per readmission. Now, again, to oversimplify, if a hospital is looking to decide, is it worth for us to invest in preventing a readmission from happening, that cutoff point is roughly $250. So if a care transition program is going to cost them more than $250, then it's actually going to cost. There's going to be more cost to. There's going to be more cost in the transition program than money to be saved. Whereas if a care transition program were less than $250 to implement, then there might be a net savings or a net financial incentive for the hospital to make that type of investment. Next slide, please. And in the next few slides, and I provided the references so everyone can digest the literature themselves, here are the approximate costs for the current best practice standards of care in terms of care transitions. These have strong evidence behind them, and I just want to highlight the approximate costs and keep that $250 number in the back of your mind. So guided care, a care transition program that utilizes clinicians, so nurses, advanced practice nurses, NPs, $1,700 per consumer per year. Next slide. The GRACE model, geriatric resources for assessment and care of elders, $1,400 per consumer per year. This also is on the backs of a clinical staff, a nursing staff. Next slide, please. The transitional care model, the NAILR model. So this model is has been a little bit more prevalent than the preceding two, and this one costs just under $1,000 per consumer per year. Next slide. And then the care transitions interventions, the Coleman model. This is present in over 70% of all care transition programs in the country. It has been the most widely adopted program, in particular with the community-based care transition program. And the dollar amount here is derived from one of the studies by Coleman and et al., focusing on the cost of the transition program. And in the second to last paragraph, as with any research paper, they describe the limitations. And in the limitations, to their credit, they point out that the study and the $196 number, it was not an econometric analysis. It was a crude estimate of some of the costs of delivering this transition program. And so in reality, it's not $196 to implement the program. And from anecdotal perspective, and for anyone that's participated in the care transitions in the past, particularly with the CCTP program, organizations that are doing a Coleman model have a very hard time breaking even when getting reimbursed $350 upwards of $400. So again, we're exceeding this $250 mark. I'm somewhat comparing apples to oranges, but it's really the order of magnitude that's important to focus here. Next slide, please. Sorry, yeah, perfect. That's great. So I want to highlight one innovation, one approach that some of our partner organizations have done, and I think this is a promising potential. It's an emerging practice that I think for home care, for skilled home care, for folks participating in bundles, and in general, any program that's doing care transitions. If the care transition program is looking to achieve more sustainable care transitions and in a more cost-effective way, potentially with less expensive staff, here's one way of doing that. So the current model, just to kind of grossly paraphrase and summarize all of the transitions models and actually bring it to a head with the Coleman model, which this is really reflecting. The staffing is based on a transition coach that is a nurse, an RN, advanced practice nurse, at least published in the peer-reviewed literature that Coleman and his colleagues put out. And so that research has certain outcomes, and I've heard Dr. Coleman speak, and I've heard folks that have worked with Dr. Coleman, acknowledge that anecdotally there is support for not using nurses, but the research was based on nurses and the economic calculations were based on nurses. The interaction between that nurse transition coach and the patient involved focus on coordinating care, doing medication reconciliation, educating around red flags, and making sure that follow-up appointments were set up. And then there was also involvement of a personal health record. And at the very bottom, I highlight here if we were to project for about 800 patients being enrolled in this type of care transition program per month, there would need to be 32 nurses hired to run this program. And depending on geographic area, the cost could be a $45,000 to a $70,000 or $80,000 a year salary. So I want to go to the next slide to provide some contrast. Our hypothesis and some of the hypotheses of our partner organizations was, what if the role of the nurse was separated out from the role of the coach? What if the nurse's capacity, which is truly care management and tackling some of the clinical aspects of care, were teased out from the less clinical aspects of care? Next slide. And so here's what a non-clinical worker, health coach, a navigator, a personal care attendant, a care coordinator who is not a nurse would be capable of doing, or at least some of their characteristics. So they may be more commonly from the same community with the same education level, same language, same cultural background as the consumer or as the patient. Simultaneously, the nurse care manager could still perform some of the more nurse level functions like communicating with physicians, triage, determining whether a patient was sick or not sick. And then in the middle area was where the roles could overlap, and potentially the care coordination, metric, or red flags, or appointment follow-up could be within the domain of the health coach. Next slide. If that were the case, and which is the case with the organizations we work with, instead of having for every 800 patients enrolled per month in the transition program, instead of having 32 nurses, according to some of the literature for the care transition intervention, what has been shown, and there's AHRQ data to support this, is that for 800 patients per month, you would only need 20 health coaches, non-nurse health coaches, supervised by a single RN. And so what that would allow is there would be a balance of non-clinical and clinical aspects of the care transitions to be tackled, and the reach of the nurse could be really optimized through this less expensive workforce. Next slide. And if we were to look at the real opportunity that I'm perceiving here, and where we have some of our clients that are going in this direction, is that they're traditionally Medicare-funded skilled home care providers, like a VNA, and they also have some portion of their organization that provides private duty services or personal care attendant services that are either privately funded or funded through Medicaid. And what we're seeing is an opportunity to take the work that's traditionally being done by skilled staff and the percentage of the work that they're doing that is not requiring the skill of the skilled staff, and perhaps offloading that to the private duty or PCA staff. Next slide. So I want to jump in and actually highlight some data for you all, because I can show a demo to everyone, and I'm happy to do that. I want to be as objective as possible here and just let the research evidence speak for itself. Here's some evidence from data that's being peer-reviewed right now, and it highlights an important finding. So we reviewed over 5,000 surveys that were completed on our software, and I can elaborate on the software. Basically, it's a hospitalization risk prediction software, and it uniquely predicts hospitalization risk using the observations of non-clinical workers. So the worker uses our app, and on the app, they have 15 questions. They document the 15 questions. And so we've reviewed over 5,000 of these documented surveys. We then noted that there were over 1,200 alerts generated. based on those surveys. An alert is basically a notification to the supervising nurse or nurse care manager that there is some kind of elevated risk for readmission. We looked at just over 1,000 of these alerts, and we found that 242 of the alerts were associated with a 30-day readmission, and then 822 of these alerts had no subsequent readmission. Next slide. So we boiled down, based on the nurse documentation, what were the characteristics of these alerts coming in? Why were the patients at elevated risk for readmission? And we grouped them into these, very broadly, two types of classifications. One was intrinsic risk factors and the other was extrinsic risk factors. Intrinsic risk factors were things like a medical condition like CHF exacerbation or a COPD exacerbation. Mental or behavioral problems included things like someone had an anxiety attack, a worsening of depression, or maybe non-compliance. Functional decline being they had some compromise with ADLs. Extrinsic factors included environmental risk factors, things like did someone have food insecurity, or did they have housing insecurity, care coordination breakdowns, including things like if a physician was called with a question, did the office never call back? So next slide highlights the breakdown a little bit greater depth. And I won't go into the detail, but these are in greater detail what the domains actually look like. So I believe these slides are going to be available after the presentation, so feel free to have a look. Next slide. All right, perfect. Here's how the risk factors broke down. And just a reminder, these are 5,000 surveys done, about 1,000 of them triggered alerts, and this is describing what did the alerts pertain to. And this highlights a really important balance between the need for skilled nurse level care team members in a care transition program, and the need for non-nurse level care team members in a care transition program. So we found the majority, 62% of the alerts, exclusively had to do with intrinsic risk factors. So things that traditionally, from a Medicare perspective or Medicare-funded delivery model perspective, this is what skilled home care is really good at managing. If we look at the green section, the intrinsic and extrinsic care coordination breakdowns being occurring together, that highlights that maybe there was a flare of someone's COPD simultaneously occurring with inability to somehow coordinate for medications to be picked up or something along those lines. The red, which is purely extrinsic care coordination issues alone. So this is, let's say, perhaps it wasn't some pathophysiologic downturn in someone's health, but rather the risk for readmission pertained to not being able to get a ride to the physician appointment, something along those lines. And then so that comprises the majority of the risk factors that we identified. Next slide. And this is going into even greater depth. So this is showing a distribution by the individual risk factors. And what I mean to highlight here is that the dark blue are the intrinsic risk factors, the kind of medium blue are the care coordination breakdowns, and the very light blue, there's very few of them, are environmental factors. And one caveat here is the sample size we derived this data from was a Medicare fee-for-service population by definition. And we looked at 30-day readmission rates. So this data is supporting what we would anticipate, which is more of a short-term Medicare population. About 1/3 of the population was dually eligible. And I'll show you all what readmission rates look like out to as far as 120 days. But this data would look different, and we have different data for a predominantly dually eligible population that has a different distribution of risk factors, which are less heavily intrinsic and much more emphasizing environmental and care coordination breakdowns. Next slide. In these next couple of slides, I want to highlight that the nurse-only staffing models may not suffice. Our data suggests that they may not suffice in actually addressing all of the risk factors for readmission. And this is just a schematic. It's me drawing in orange triangles, but it's meant to represent the concept. So next slide, please. What these triangles are showing is if we were to highlight the types of risk factors that a nurse would be really well suited to handle, those would typically be intrinsic risk factors. And it's not that it's her scope of practice that limits her to just intrinsic, it's more so the bandwidth. So nurses, especially even doing skilled home care, are busy, have high volume panels, and need to tackle the put out the fires that are immediate and then move on. On the flip side, if you look at the role of a coach or a community health worker or a navigator, their job is to sit down and listen and hear the patient out and try to get to the bottom of what are the care coordination limitations or what are some of the environmental factors that are at play, and then serve as a conduit to the nurse to see if, do we need to think clinically about the inability to get an air conditioner in the middle of summer for someone with COPD, or is that purely a resource need and maybe they need to be plugged into a social worker or get access to emergency funds, things like that. Next slide. What we tried to do in our hypothesis from the beginning was if we could somehow connect a non-clinical worker that's the main touch point with the patient with the supervision or working in partnership with a more clinically trained person, we may be able to get a really nice balance between addressing the intrinsic and extrinsic risk factors for readmission. And that's really the foundation for this health transitions model, which is essentially an elaboration of the previous types of transitions models I described, with the exception being that the staffing ratio is flipped. It's many non-clinical workers working in tandem with a single or even a partial FTE of a clinician like an RN. Next slide. So this gets to the actual technology and what it does. The technology, as I alluded to, it's a smart survey platform, and it predicts hospitalizations. It's unique because the hospitalizations are predicted based on the observations of these non-clinical workers. There's really three components to it. The first being a survey library. It's a library that is continuously being evolved. There's over 2,200 questions in the library, and they're all tested and psychometrically validated, which is somewhat of a laborious process because we have to actually show the performance measures that question is effectively detecting risk. When the questions are deployed, I don't think I highlighted it before, but there are 15 questions on any given survey, but those questions for any one patient will change each time the survey is administered. So our technology actually anticipates what are the risk factors for readmission and what are the best questions to deploy on that survey. And for example, if a patient is acutely decompensating either because of their pathophysiology or because there's so many social risk factors, as many as all 15 of the questions will completely change in between each survey administration. So for a typical Coleman model, let's say, there might be an in-person visit 2 days after discharge from the hospital, followed by a 7-day follow-up phone call, and then another 7-day follow-up phone call, and then another 7-day follow-up phone call for a month. So each of those touch points between a coach and the patient would have, if they're really changing in risk, would have 15 different questions each time. If there was a patient who was stably ill with chronic conditions that were smoldering and not flaring up, there may be as few as a third of the questions that are going to swap out. The technology predicts that, and the goal is how to not create new workflow for the worker while still capturing meaningful data really quickly in about a 2 to 3 minute survey. So that's the surveys. The risk prediction algorithms, as I alluded to, they anticipate what questions need to be deployed, and all of that is based on what is the projected hospitalization risk for the patient, and I'll share with you all that data shortly. And then finally, the analytics. They're important when we go beyond the surveys. We are looking at a lot of data. Most of when alerts are coming in, as I described, it's a reactive way of using the data in a productive way, but we have analytics that think proactively and provide dashboards and hotspotting tools so that we don't have to wait for someone to go downhill. Next slide. So I'm going to show with these two slides just the before and after to highlight the functionality of this technology. So before the technology is in place, what the typical workflow is something like a personal care attendant will be in the home helping with activities of daily living. They may detect certain glaring issues. If someone is obtunded and blue and on the floor, they'll pick that up, or hopefully they'll pick that up and likely call 911. Many times, most times, they pick things up too late or they don't pick them up at all, and then it's not their fault, it's just their scope of practice. And so what ends up happening is by the time information is presented to any clinician, it's either in the ED or it's really late to the nurse care, getting to the nurse care manager. Next slide. Now, with our technology in place, the difference is that the same help with activities of daily living is still happening, or the same education is happening, or the same care coordination is happening between that non-clinical worker and the patient. In addition, that worker does a 3-minute survey, and the 3-minute survey, 1 in 5 to 1 in 10 times a survey is administered, it will trigger an alert to the nurse care coordinator or the nurse care manager. And that alert will be in the form of a text or an email. It'll very concisely highlight what should that nurse be most worried about right now. And in many cases, not all, but many cases, will actually provide some decision support to suggest, here's what's been done in the past that is statistically associated with improvements, like a follow-up phone call or perhaps a home visit or sending someone to the PCP. And in this setting, information is brought to the attention of a nurse much faster. The nurse is capable of doing two very important things. The nurse is able to follow up with a phone call, which happens 97% of the time she gets an alert. And when she calls the non-clinical worker or calls the patient, she does two things. One is she determines, is the patient sick or not sick? And then she determines where and how does triage need to happen, and at what level does care coordination need to happen? Does the patient need to go see the PCP urgently that afternoon, or is the patient fine to be followed up with a phone call 3 days from now by a direct care worker? So that is totally within the wheelhouse and the scope of practice of the nurse care manager, but really is not within the scope of practice of a non-clinical worker. And this is where the magic, so to speak, happens. Next slide. This is just a screenshot of, sorry, the text sizing is a little off with the PDF here, but the screenshot of roughly what the technology looks like. It's yes, no questions. There's some other types of questions. There's some pictorial representation, but for the most part, it's really simple yes, no questions. And when an alert is triggered, and it's automatically determined by the technology, then a nurse will get an alert as a text or an email, and then she'll see some very simple elements of the care plan. And in that care plan, she'll see hospitalization risk, as we're showing with this graph here, with the red being highly, orange being moderately, and yellow being mildly elevated risk for 30-day readmission. And then as well as previous episodes that may contribute to her better understanding of what's going on with the patient. And this is one thing to highlight here, and I don't know if we'll have time to really get into interoperability, but we represent a care plan here. That care plan has elements of data that are also important and in many cases derived from an EMR discharge care plan. When the care plan elements in our technology need to then perhaps be sent back to the hospital, those care plan elements stay the same in how we define them and how the EMR defines them. And where there's a really interesting body of work happening right now at the federal level is creating the interoperability standards, not just for communication between acute care or clinical settings, even if it's PCP settings, all of the interoperability that Meaningful Use has pushed. What now there's happening is interoperability between long-term supports and services providers, and also the intersection between LTSS providers and the medical world. So we do a lot of that. I won't dwell on it too much, but that's just to say a care plan or a plan of care or a service plan, lots of different names, lots of different definitions. All of that is increasingly being unified with a common language so that information can be very streamlined in its sharing, and we're already doing that. It's a little tedious in getting people to the table and aligned, but that work is already being done, particularly in Massachusetts. Next slide. This slide highlights some of those dashboards that I alluded to beyond what the surveys are capable of. So number one highlights the hospitalization risk, as I showed in the previous slide, and this risk is important and different from existing risk prediction tools because most hospitalization risk prediction tools will use clinical data or ICD-9 or ICD-10 data or some kind of administrative data that at some point was captured through a clinical interaction. The problem with that is when a patient leaves a clinical setting, then there's no way of predicting their risk. And so what we tried to do is we thought, how can we fill that blind spot between the doctor visits? And we thought if we could somehow make the non-clinical worker the sensor, then we could do essentially continuous prediction of risk, and we don't have to wait for someone to get readmitted in order to then re-risk stratify them. Rather, we want to risk stratify them when a home care worker goes out to see them, and if there's something smoldering and concerning, we'll act on it so the person doesn't bounce back. And number two highlights how all of this is mobile. With mobile, we can geomap anything. With geomapping, we can identify some interesting trends. And so the hot spotting that we can do, the biggest value, and there's a few different values, but the biggest value is that instead of the current approach to identifying gaps in care as being code level and 3-month-old data, what we have is a person's direct location and real-time data. And so if we wanted to say, how do we provide a very targeted care transition intervention to a specific set of people, we could say, well, here's the project housing building where the highest readmission rates are, and then overlay that with where are the worst, where's the worst continuity between Meals on Wheels routes, for example. Number three highlights how our data can directly and indirectly identify gaps in quality measures, and quality measures determine reimbursement for managed care organizations. They determine reimbursement for ACOs and hospitals, and most of the access to quality measures, as I alluded to with the hotspotting example, they're old and they're too high level, and so our data has direct and indirect quality measurement that is very precise in real time, so it just makes it that much more actionable. And then number four highlights, I think probably the most exciting part is, for me, the most exciting part about where technology is going and just where the body of research is going is that this workforce, the non-clinical workforce, PCAs, navigators, it's not a trusted workforce. So I, as a clinician, I'm a physician. I was an ICU pediatrician, so that is a disclaimer. I still, when I have a patient that's acutely ill and I tee them up and I'm about to send them home, there's no way for me to guarantee the quality of the home-based services that they're going to get. There are some organizations that I know provide better care than others, but there's very little standardization. And so when I then switch roles in my entrepreneurial world, I want to advocate for this workforce, and I want to make sure that when there's deficits, those deficits are identified immediately, and it's not the 30 to 40% turnover rates that exist now, but rather let's not waste the money of hiring and firing a bunch of people all the time, but rather let's spend a fraction of that money on identifying the gaps in knowledge or the gaps in process and use that insight from our data to then direct how remediation or support happens. And one example is we can identify the top quartile, bottom quartile of performing workers, and that allows our partner organizations to target the underperforming workers, do a root cause analysis of why are they underperforming, and then take their top performing workers and actually give them bonuses. we now have a couple of clients that are giving bonuses. I mean, they're tiny. They're up to $2 an hour bonuses tied to how many prevented admissions have been achieved, and some other measures, but basically it's aligning the more improvement in outcome a worker contributes to, the more that they can get paid, and this is turning out to be a really huge motivator of change in behavior. Next slide. This is an example of some of the data that we've put out. This alludes to a data set of 561 Medicare fee-for-service patients. We compared their hospitalizations for, I believe it was a 14-month period prior to the intervention, being our technology, and then followed them for a 6-month period after the intervention. It was not a randomized controlled trial, but it was a pre-post cohort analysis, which was relatively well controlled for variables, but there's definitely confounding variables here. Nevertheless, the effect size, the magnitude of the outcome is pretty substantial. We had a 39, sorry, there's a dollars, unnecessary dollars in here, 39.6% reduction in 30-day readmissions. When we averaged that out, if we were to look at a per patient or per member, we framed it per member because there's more and more discussion with MCOs looking at this data. On a per member per month basis, that would be about a $109 savings. And the graph here highlights that this isn't just all savings. It requires an investment of resources, but the investment isn't so much on the technology. Technology is cheap, and technology should never be the rate limiting step, ours or anyone else's. But rather, what we need to recognize is it takes work and it takes cost in order to save money on admissions or readmissions. And we highlight here in this first column that there was about $200,000 in increased care coordination services, so calling VNA, more referral. We've seen actually a 15 to 20% increase in referrals to VNA at all of our client sites because we're identifying more and more skilled needs with these non-clinical workers. But if you compare the cost of engaging a nurse to do a home visit compared to a avoidable admission, the costs don't compare because there's such tremendous savings from prevented admissions. And hence the final column showing net savings, which are pretty substantial. And it's about $2.54 saved for every $1 invested altogether. Next slide. And I'll be wrapping up here just in the next few slides. I know we want to leave 20 minutes for questions, but briefly, I just want to show the data that behind why these outcomes are happening. And the why is because the technology and the algorithms can actually predict hospitalization risk. And this is showing the green, the blue, and the orange, 3 different risk scores. The green is showing risk scores purely based on the observations of the non-clinical staff, which is interesting because we've shown that there is a statistically significant prediction of 30-day readmission risk just using the non-clinical staff. Incorporating the nurse input to interpret the non-clinical staff observations, it improves the prediction of risk. But what's more important is if you don't have nurses involved in one way or another in the care transition process, we can detect all the risk we want, but no one may be able to do anything about it. And that's a really important takeaway from our research. Next slide. So this slide shows if we take risk prediction out to 120 days, that our risk prediction that uses both the worker's observations and interpretation by the nurse, the risk prediction is still statistically significant all the way out to 120 days, which starts getting into the realm of not readmission, but just predicting admissions in general. So if, again, we want to focus very limited resources on which populations do we want to target interventions on, that this technology has the evidence to show that we know which populations need to be targeted. Next slide. And briefly, this is data showing when we think about what care team members are involved in the care coordination episodes in response to the alerts. We highlight that the highest bar here, the nurse care manager, this is the recipient of alerts. So it basically goes to show that they respond to almost all of the alerts, usually by calling the coach or the patient what's interesting here is the patient and health coach involvement, or the non-clinical providers' involvement. And these are not mutually exclusive. Right? These don't all add up to 100%. But what's important is the patient is actually very heavily involved in their own care coordination. Sometimes they can't. They're not empowered or activated enough, or there's just too much complexity to their care. So they do need care coordination to be offloaded, and that's where we found health coaches or the non-clinical workers to be incredibly valuable. And another important finding is that over 40% of these episodes required skilled nursing to be involved. So this reflects the 62% of all of the alerts that were due to intrinsic risk factors. Again, reinforcing the notion that care transition programs that use only nurses are missing the mark. They miss the care coordination elements, just because for a nurse to do care coordination or certain elements of care coordination is not efficient. And then the flip side is community-based organizations that don't have any clinical staff. It's okay if they don't have the clinical staff, but if they don't involve a clinician, like a nurse at a PCP's office or having their own nurse on staff, they're missing opportunities to prevent readmissions as well. Also importantly, physician involvement was really low. Only 1 in 5 episodes actually had a physician involved, and urgent and emergent care was almost non-existent, which was the goal. Next slide. And so I want to close with just highlighting the opportunity, particularly for home care and skilled home care. So bundles, in particular Bundle 3, I can elaborate in the Q&A on the difference between the 4 bundles. But Bundle 3 is basically allowing a post-acute care provider, such as a home care company, to convene a bundle and go at risk for a 60 to 90-day period for a particular condition. So if someone goes to the hospital, they get admitted for heart failure, and Medicare, you were to go into a contract with Medicare to say for the next 60 days, I will be at risk for all costs pertaining to heart failure. All costs including hospitalizations, including physician visits, including home care, everything. And roughly it'll be like in the $24,000 or $26,000 range. So if you prevent any readmission from happening and you only spend $24,000, but you get paid $26,000, you get to keep the rest. If someone gets readmitted, then it costs you $40,000, and you're only getting paid $26,000, and that eats into your budget, and that's a loss. The opportunity here is most of the folks we work with are barely breaking even, if they're breaking even at all, at the $24,000 to $26,000 range. What they could be doing, and what they are doing now, and we've got a few folks that are working with us on this, is tapping into the private duty arm or the non-skilled arm of their business, and in the 6-week or 8-week or 12-week readmission transition program in the bundle, instead of having nurses being the main touch point for all 60 days, instead they're having a nurse be the touch point for the first 7 days or 14 days, and then the main touch point becomes the non-clinical worker, using our software so that when the software detects that there's some kind of elevated risk for admission, the nurse gets re-engaged. So really the nurses are only being utilized when there's a nursing need being identified. Next slide. This just highlights some of the potential risk that's being carried. So these 3 groupings, DRG 190, 294, and 291, they're for common conditions that are very amenable to driving down costs by offloading the role, offloading some of the work from a nurse to a non-nurse. And so that if a readmission is prevented, then the cost of administering one of these bundles is really, really low. And this is 30-day time periods, and it's older data, but the delta is really what's really important. Next slide. And finally, and I apologize, I'll have to breeze through these, whenever doing anything new, even if there is evidence base for it, each healthcare microsystem, each deployment is very unique, and so it requires a rapid cycle approach to figuring out how to most efficiently deliver that care. And so that's where the role of quality improvement comes into play. Next slide. The quality improvement, very high level. This is just highlighting the model for improvement and basically suggests that first we need to identify an aim. What are we trying to achieve by what time frame? Making it an aggressive goal but a reachable goal, and being very, very precise of what exactly milestone are we trying to achieve, and then selecting good measures to make sure we're confirming we're actually achieving that milestone. And then the drivers part is very crisply identifying what are the drivers or barriers to achieving that goal, and then doing a repeating rapid cycle approach to testing whether we can very quickly achieve that aim. The more quickly we test, the less expensively we test, the more efficiently ultimately we figure out what is the right way of delivering the bundle, or what is the right way of delivering the care transition program. Next slide. So these three slides just highlight the example of, let's say right now, a common trend is organizations will get a grant and they'll spend 2 years testing a hypothesis. And at the end of the 2 years, the outcome either dwindles or they run out of money and they don't have an opportunity to test alternative hypotheses. Next slide. Now, if you introduce a few different tests during that time period, you have an opportunity to maybe discover something new. Next slide. If you do the testing really frequently and regularly and systematically, you have an opportunity to much more efficiently figure out what is the correct way of delivering care. And no one ever has the kind of crystal ball. No one actually knows what it, even with applying methods from rigorous research in the past, those methods oftentimes don't hold in a unique local healthcare environment. And so even with evidence-based practice, implementing that practice using QI is much more efficient at figuring out what nuances will actually work locally. Next slide. I'll breeze through. Why don't we click through next slide, next slide, next slide, next slide. One more. Perfect. Okay. So I'll encourage everyone to kind of refer back to these slides. This is an example of an actual driver diagram for one of our customers where we went through step by step, what were they trying to achieve, their aim, what were the barriers to the aim, primary, secondary drivers, and then what were the change strategies, the things that they wanted to test so that they could eventually overcome the drivers and get to the aim. And this is a screenshot of a very bootleg tool we built for them, the PDSA wizard. But what it highlights is by systematically chipping away at the drivers and doing it quickly, it could, home care companies or community-based organizations or hospitals or payers can much more efficiently get at achieving the aim rather than doing an RCT for 5 years. Next slide. And it's just an example of actually what the final process looks like once all the drivers are addressed. Some change strategies worked, some didn't. The ones that didn't work, we squash quickly. The ones that did work, we scale up. Next slide. And then finally, I think that's the last slide. So this is a reflection of the analysis we've done on a real PDSA wizard for one of our clients. And when trying to look at when they were identifying the aim, whose problem were they solving? And this is an area agency on aging specifically. So they identified that they were solving their own problem or trying to solve their own problem 61% of the time, the hospital's problem a third of the time, and the combined hospital AAA problem just under 10% of the time. And then when we look at star ratings or star categories, we have this breakdown of which quality measures we're being focused on. And in retrospect, when this type of data is brought back to the board of directors or executive director, it gives them a glimpse into how are they actually operationalizing strategy. And in this case, for this customer, their main strategy was actually focusing on managed care. And there is no managed care identified in any of their PDSA cycles when you look at the who's problem circle. And so that caused them to pivot and think differently about how they do their PDSA cycles. Next slide. Cool. So I'll finish with this, and this is actually probably the most important slide. I sell technology and I'm a physician, and we all do, I think, pretty important work. But I think a lot of this we can lose sight of what's really important. And I think what is really good for business and what's also really good for the consumers is thinking about the consumer and thinking about the patient and kind of putting ourselves in their own shoes. And so this is my grandma who passed away a long time ago because of pretty poor home care, not home care's fault, but it's a systems issue. And so I think if our app was around 15 years ago, my grandma probably would still be around. And this is just as a reminder that it's not about the app, it's about the staffing and the processes, and technology can only help so much. So any questions?
Thanks so much, Andrey. I really appreciate the presentation. I thought it was really well done. If any of you on the line have questions that you'd like to ask Andrey Ostrovsky, please send them through the Fuse webinar chat box. And in the meantime, my question for you, Andrey, is that you've developed sort of this, I think you refer to it as an mHealth transitions model, obviously, based around the survey and, sort of the algorithm you guys have developed for your Care at Hand app. And, as I've been thinking about it, because the audience here on this webinar is, primarily one that's home health providers, some are VNAs, some are home health agencies that are proprietary. I just want to be clear. Do you see your model as one that can be adopted by home health agencies and VNAs, where a home health nurse is serving as that nurse care manager, and you have home health aides, different types of paraprofessionals who could be the ones in the home utilizing your app?
It's a great question, and it's not a hypothetical. This is the way in which we've deployed. But I have to be honest, it hasn't been our area of biggest growth, because I found that if we look at the non-skilled, or I hate that term, but the home care agencies that are not predominantly Medicare funded, but mostly Medicaid or private duty, there has been a reluctance. It may be a reluctance issue, it might be a capacity issue, but to develop effective care transitions programs, it hasn't moved as quickly as other healthcare verticals. With Bundle 3 coming out, we're seeing a much higher uptick in home care companies, especially predominantly Medicare-funded home care companies, who are doing bundles and using our software in exactly the same way that you just described. So our origins were out of home care. That's where our company started servicing a technology. We moved away from home care because the industry as a whole was a lot of barriers to adapting care transitions programs and scaling them. But now there's more and more of a financial driver for that. And I think the most important part is the workforce that we built the technology around, a non-clinical workforce, is a predominantly English as a second language, above 50-year-old female direct care worker. That is the main individual that is going to be collecting data. And so that's the foundation of all the algorithms, and everything else beyond that, as long as there's some kind of clinical insight or supervision, and there's a financial incentive to keep people out of the hospital, our technology has worked well.
Right. I guess, we get to, I think that here's one of the challenges in this area when you deal with home health. I think that there are a lot of different types of terms that are being used to describe those who provide services in the home. And so, what you just described to me was that initially you thought that the audience for adoption of the technology and of the model was probably going to be home care agencies, where most of the services that were being delivered by, home health aides. We sometimes call them direct care workers or paraprofessionals, but in other words, only the aides as opposed to skilled nurses. And so, where I was going with my question was that, most of the members of the Alliance, their focus is operating as certified Medicare home health agencies, and the focus is skilled nursing and therapy. They do have aides because home health aides are used to provide services, but it would be incident to those skilled nursing services. But to me, it seems like what the model you've described would fit very well into these types of agencies. And I do think that as we think about how do we optimize the home health interdisciplinary team, I think increasingly we're going to be needing to look to technology as ways to enable better use of our workforce, and really be able to stretch the workforce we have, because one of our concerns is that we're not going to have enough nurses, right? So in a way, what you're doing, right, is really enabling us to extend beyond just our skilled nurses and be able to make better use of our paraprofessionals who are out there by putting technology in their hands to fill out surveys that can be sent back to skilled nurses who are acting as care managers and helping to develop follow-up steps based on that information they're collecting in the home. Is that an accurate description?
It is, and my goal, and I think as should be the goal of any designer or technology provider, is we should not impose new workflow or new responsibilities on a workforce unless they ask for it or unless it really improves what they do. And so whether it's a community health worker who's doing empowerment and activation of a patient and care coordination, or if it's a paraprofessional direct care worker who's helping with activities of daily living, or it's a transition coach who's doing a med rec and follow-up appointment, any of those roles they're all very different. But the key and unifying factor is that they don't have a clinical scope of practice. And so whatever the delivery model is, if the intent is to pick up early warning signs of decline in medical or social or environmental, that is really the ripe opportunity. And I think all of the above. I mean, we have Meals on Wheels van drivers that are using the software, and that that meets our requirement for a quote unquote not clinical worker. So I think there's a lot of opportunity here, and I think a really big key is testing and not taking 2 years to test, but testing really inexpensively, because everyone's bandwidth is limited and risk is relatively high, so we need to mitigate that risk. And again, technology is just a sidebar. The key message is I would love to see more of the home care industry understanding and utilizing quality improvement as a means of piloting, because I think that just leads to more innovation and more quick discovery of value for our consumers.
Sure. Okay, we've got one question that came in. It says here, I heard several times that a nurse model alone misses the mark, but this very model in the Netherlands called Buurtzorg is very successful. Community nurses work in teams and serve both roles of nurse and community health coach. It has saved the Dutch health ministry a lot of money while improving quality, and they use similar IT to optimize care. So we're wondering what your thoughts are, and would this model not be successful here even if it was using care at hand?
I think it's a great comment. What has not been done is a head-to-head comparison of that pure nurse model to a blended model, and looking at the econometric analysis, looking at how much does it cost net to operate in savings, and then comparing that to outcomes. And I think what would likely happen is that model, although it has great outcomes, it would likely have comparable outcomes, if not better outcomes, with a likely cost savings. So the literature there from Europe is very comparable to the literature here for the Coleman or the Naylor model. And what has been done is the testing of the opposite. I mean, we have some of the preliminary data on that, but in terms of wholesale testing, there's been such a overemphasis on what the clinicians can do and underemphasis on optimizing the cost and the care team that I think is a valid point, and I agree with it. But I think there's also opportunity to improve even that data.
Right. I mean, in a way, what it raises the question of is whether or not, well, I mean, certainly because cost is going to be an issue in our healthcare system, we have to think about sort of operational cost in implementing these types of transitions programs. And to the point of the questioner, perhaps, and you raised this a little bit yourself, perhaps what's needed is like a comparative effectiveness study, where you're comparing head-to-head, both the cost and the outcomes associated with, exclusively nurse-led and run care transitions models, comparing to maybe nurse and paraprofessional care transitions models that are using, mobile health technology as well. So both and compare.
Yeah, I think it's great to do. I think both things should be done in parallel. I think comparative effectiveness and just research in general should be done in the space so that we collectively have generalized knowledge and we can have a well-controlled body of well-controlled studies to reinforce the existing body of literature. But at the same time, we can't ignore that the immediate need to innovate and evolve, and that's where QI comes into play. So I think what should be done and what is being done in certain organizations is those organizations are participating in research, but they have a bottom line to meet, and they can't wait for NIH dollars to come through because they have to bill or they have to pay their staff. And if a culture were to be adopted where there's more acceptance of quality improvement and more capacity to do quality improvement, I think we can have 3-month spurts of value discovery, 3-month spurts of QI testing that would tell us if there was a there, and then more broader research can be done in the background or in parallel. And I think the two go hand in hand and are both very important.
Right. Absolutely. Well, we've actually gone over time, but I want to thank you, Andrey, for spending this time with us and describing the model you've been building and so much data that you shared with us. I thought it was tremendous. I want to remind everybody on this webinar that we've recorded the webinar and we have Andrey's permission to post his slides. So we'll be posting his slides on the website immediately after this call, and we'll post the recording of the webinar within a week or so, as soon as we're able to get the recording and get it up in an edited fashion. So I want to thank everybody for participating today. I believe that Andrey's contact information was on the slides, and you can also certainly reach out to me, Teresa Lee, at the Alliance should you have any other follow-up questions. And with that, I'll just wish all of you a very good afternoon, and thank you again, Andrey, for spending your time with us.
Thank you so much. Thanks for everyone for the questions.
Okay. All right, goodbye.